Okay, time to get started again, and just few words to thank all the players in this organization. So, thank to Nana Onlus, thank to Maria Teresa Voso for this kind invitation, and also for consenting to this change in the agenda. Actually, I should have been here yesterday, but I couldn't. So thank you very much, Maria Teresa. So having said that, I will pass the moderation to Professor Constance Donner. Connie, up to you.
Thank you very much. So I'm really happy that we have now the session on the selected abstract presentations by the earlier career scientists. And we were really happy that we received a number of really good abstracts from the young scientists. And it was hard, Maria Teresa, for us to select the top best abstracts. That did not mean that the others were not good, but we are very happy that we have 5 abstract presentations today. And I think we should start, in the interest of time, with the first presentation, which is given by Enrico Attardi from the University of Rome. And we are looking forward to your presentation, Enrico.
Thank you. Thank you to the chairman for the introduction, and thanks to the organization for giving me this opportunity to present my work. The title of this presentation is 2022 Classification of Secondary Acute Myeloid Leukemias. Nothing to disclose. So during the last years, to update it, new classification and a new prognostic risk stratification have been made, in particular concerning the World Health Organization in 2022, the 5th edition, the International Consensus Classification. And we also have a new prognostic risk recommendation by ELN. So secondary AML are probably the category in which the greatest changes have been made. And herein, I reported the major differences between the old and the new classification. As you can see from the picture, a previous history of MDS or MDS-MPN that was disease defining for WHO in 2016 remain as this is defining in the new edition, but conversely, for the ICC, it is only a diagnostic qualifier along with a germline predisposition and exposure to previous cytotoxic therapy. So from a biological point of view, secondary ML are also related to myelodysplasia genetic profile, and in particular the MRC changes in the new classification due to the implementation of new genetic profile, particularly concerning the MDS mutational profile for the WHO 2022 in the subcategory named myelodysplasia-related AML. And for the ICC, particularly 3 subcategories that are MDS-related cytogenetic abnormalities, MDS-related gene mutation, and AML with a TP53 mutation. The blast cutoff of 20% remain as an important cutoff for the AML diagnosis in this category of secondary AML. And we also have some minor changes, such as the presence of the mutation of RANX1 in the ICC classification. Conversely, in WHO 2022, it is not present due to the lack of its specificity, and some cytogenetic abnormalities such as 11 and 13q deletion in the WHO 2022, and trisomy 8 and 20q deletion according to the ICC. So from the secondary AML perspective, the new ELN risk stratification, the major important change is related to the presence of the myelodysplasia-related gene mutation that confer an adverse risk prognosis if they are not accompanied by some genetic profile related to the favorable risk of this new addition. So in light of this novelty, with my colleague Ariana Savi, decided to study a cohort of 449 AML patients according to the old classification in order to test the clinical impact of the new classification and also both diagnostic and prognostic classification, focusing on the secondary AML and the therapy-related AML. We also extracted the data from a validation cohort of about 400 patients and with a primary AML and more than 100 AML patients with unknown data related to an antecedent neoplasm or cytotoxic therapy. So a total of 1,001 AML cases were analyzed that derived from Tor Vergata University in Rome, Humanitas Cancer Center in Milan, Cleveland Clinic Foundation, and publicly available sources, in particular the BEAT AML Master Trial. So among our cohort, a diagnosis of secondary AML was described in 30.3% of patients. As you can see in the pie charts, this is the distribution of the secondary AML according to the old and the new classification. And we described a reduction of the subcategory according to 2016 WHO, the not otherwise specified subcategory that reduced due to the implementation of the molecular profile that you can see in the pie charts regarding both new diagnostic classification. And we also, in this setting of patient, we described that the majority of them, about 75% of them, presented one of the subcategories related to a myelodysplasia genetic profile, that are the myelodysplasia-related AML according to 2022 WHO, and the 3 different subcategories related to the ICC. So examining the dynamic reclassification of these cases, we noticed that about 1/2 of patients in the NOS subcategory moved from 2016 WHO to the myelodysplasia-related subcategory, due probably by for this implementation of the extended molecular profile. Interestingly, the RANX1 provisional entity by the from the old edition, the majority of these patients moved to the myelodysplasia-related subcategory, and although this new classification did not present the RANX1 mutation. And probably we noticed that this patient also present the co-occurrence of other somatic mutation MDS related that could be enough to a proper diagnosis. We also noticed that about 27% of patients, according to the ICC, presented the TP53 mutation, and this is expected in this cohort of secondary and therapy-related AML. So this is important to notice this relevant percentage. So going deeper to the prognostic risk stratification, we notice, as expected, according to the previous edition of ELN, that the majority of secondary AML presented an adverse risk prognosis. But interestingly, only 5% of patients moved from the previous intermediate risk according to the ELN 2017 to the adverse risk of AML according to the new prognostic risk stratification. So we can say that anamnestic data of a previous neoplasm or cytotoxic therapy may predict the adverse risk also according to the new ELN 2022. So we therefore decided to extend our analysis, and we considered the secondary AML from a biological perspective. So considering the secondary AML with a genetic profile MDS related, and we noticed that about 1/3 of the entire cohort present a mutational pattern MDS related, and we did not notice any particular differences between the new classification. And probably the most relevant thing is that the ICC we should apply is a hierarchical classification in which the molecular profile supersedes the conventional karyotype. And this is a very important issue because without that, in all parts of the world, it may be difficult to perform the molecular profile. So we decided to analyze this MDS-related cohort by reverse hierarchical point of view. And we noticed that from a conventional, a cytogenetic point of view, the majority of patients, in particular the 55.9%, majority than an half of patients, have at least one cytogenetic alteration that could be enough to have a proper diagnosis of myelodysplasia related AML. So it could be an interesting point of view in some situation in which it could be difficult to perform the molecular analysis. From a ELN prognostic risk stratification point of view of this MDS-related cohort, we noted that most of them, according to the new prognostic risk stratification, present an adverse risk prognostic risk. And we interesting found that about 80% of patients according to the old risk stratification, move from the intermediate risk to the adverse risk. So we decided to study the impact of the molecular profile in the overall survival. So we decided to select patients with adverse risk, but normal karyotype. So patients with at least one adverse MDS-related mutation. And stratifying patients with one mutation with another cohort of patients with at least two mutations, we noticed that a difference in terms of overall survival. In particular, we notice an inferior overall survival of the cohort with more than one mutation. So we can say that probably only one mutation could not confer this mal prognosis. It's just a suggestion. So in conclusion, the majority of secondary AML are characterized by MDS-related genetic profile as expected, according to the new 2022 diagnostic classification. And although the secondary nature of AML prior to MDS or MDS AML therapy related is now applied as a diagnostic verifier, it continues to maintain a predictive role for defining a non-favorable outcome. And although NGS analysis is now pivotal, it must be taken into account that it may be not widely available, and more than half of our patient MDS related could be characterized only by the use of the conventional cytogenetic. And last but not least, a caveat with regards to the adverse prognostic role of a single MDS-related gene mutation in AML with the normal karyotype calls for further validation studies. So I want to thank every single colleague that take part in this work, in particular my mentor, Professor Maria Teresa Voso, but also the colleagues Arianna Savi, Carmelo Gurnari, and Beatrice Borsellino, and I want to thank you all for your attention.
Okay. Thank you very much, Enrico. Are there questions from the audience? If not, I would like to start with a comment and then with a question for you. Well, the comment is that the data that you presented are more or less very in line with those presented at the ASH meeting by one of the colleagues from the group of Afferlach, Dr. Afferlach. So, and the final message was that the scientific community is waiting for a sort of unified classifications in a way that we can speak a common language. And the question is, you know that for therapy-related or more generally speaking, secondary AML, we have a specific therapy now available that is CPX-351. And of course, in this situation, the question about the future attitude of physicians, will it change or not based on the new classifications and having in mind the label of the drug?
Thanks for the question. I think that we don't have many peculiar novelties regarding this new classification, but I want to explain this concept. Obviously, the molecular profile could help us into the definition of these categories, and this is essential. So we need this new edition of the diagnostic classification. But on the other side, I think that we have the tradition to treat this type of patient in a peculiar manner, considering the antecedent history of myeloid neoplasms. So I think that we just have the expertise to a correct management of these patients. On the other side, it is essential to perform molecular diagnosis. Think about the presence of TP53 and the possibility to use novel drugs such as magrolimab. So I think that we can personalize the treatment, taking into account this important novelty related to molecular profile.
Okay, thank you. And of course, all of this requires a strong logistics that, of course, have to be.
Absolutely.
Yeah, we have to put in field it.
Yeah, maybe also a comment from my side. I mean, the ICC, for sure, you are right. This is a challenging classification because it includes a number of novel genes that where we have to provide the mutation status to classify our patients accordingly. On the other hand, it is a development based on the insights we have obtained within the last years on the biology and the pathology of these diseases. And as you have shown very nicely with your figures, it allows a refinement of the classification of these patients, and as a consequence of that, it also has a refinement with regard to prognosis. And with the development in all these with regard to therapy, I think it will become the future, because we have to know the distinct gene signatures from these patients, because we will get more and more drugs available that are allowing to do a personalized treatment based on that risk. And as I mentioned before in my talk yesterday, also karyotyping is a kind of challenge. I mean, this is really highly depending on the quality of your material, on your chromosomes, and who is doing that knows that I think in a significant proportion of these patients, we will not be able to see all the aberrations, or to have always 20 metaphases analyzed. And if we talk about gene mutations, then we are talking about also subclones, which seems to play an important role. So I think this is a developing process that has hopefully, or will hopefully, come together with the WHO in the future again, because for us, for the clinicians, it is very important to speak with one voice and to have one classification. But this is a really nice work, and you showed some, I think really very important data to confirm what has been developed within the ICC and also within the WHO. Thank you.
Thank you too.
Thank you, Rico.